Hi guys, I just briefly wanted to talk about some differences between spinal and epidurals and really what happens when we do an injection in the spinal fluid for spinal and epidural injection for epidural, and why do we have some differences? So let's say this is cross-section of the spinal cord. Spinal cord is covered by a very thin membrane called the pia mater that's really adherent to it, so I'm not going to draw it. One layer up is the arachnoid matter. So A for arachnoid. And it contains a space full of fluid that bathes the spinal cord here. So that space is called the subarachnoid space, or let's call it SAS. When we do a spinal injection, we come with our needle and enter the space and inject our local anesthetic in the fluid that surrounds the spinal cord. Usually we do our injection below the level of L2 in adults, so there's no spinal cord, it's just the nerve roots that come out of it at that level. So we don't poke the spinal cord or inject numbing medicine inside the spinal cord and cause injury. So we do our injection into spinal fluid, and the fluid migrates cephalad and caudate, and since we're doing it in the lumbar region, it always covers the lumbar and it goes distal, it goes caudate, so covers the sacral roots and coccygeal roots quite readily. And also it migrates, as it migrates cephalad, depending on the volume or and the amount of local anesthetic really that you inject, the higher you inject, the higher the dermatome levels that you'll cover will go. So if you inject, let's say, 3 cc of 0.5% bupivacaine, you get to, let's say, T8, T9. If you inject more, you get higher. If you inject less, you get lower. But you will that's the height of coverage. You will almost always cover the lumbars, the sacrals, and the coccygeal dermatomes. So local anesthetic diffuses to spinal cord, the upper motor neuron, and affects them. Also, the roots that come out of the cords are affected. So it's not just the spinal cord. And there are some who believe that it's not really spinal cord that's affected and it's just the roots. But since they're not covered by anything and they're very thin as they come out of the spinal cord, that's why the spinal is so fast. The onset. So the next layer, superficial to the arachnoid, is the dura mater. Here's D for dura. And the space between dura and arachnoid is called the subdural space. This is not a real space. We don't really target it to inject any medication, but sometimes we accidentally inject in there when we want to do spinal or epidural, and then we get a very bizarre kind of a spinal picture, like a one-sided spinal, which shouldn't happen, and or a very patchy spinal, because there's some septation always in here, so we don't get a complete spinal here. But we don't target this layer. Now, superficial to the dura mater is the epidural space. And posteriorly, epidural space is covered by a very thick ligament called ligamentum flavum. And then you have the ligaments between the bones, the interspinous ligament and the supraspinous ligament, a little further out between the spinous processes of vertebra. So let's say this is the lamina, this is the transverse processes, and this is the spinous process. So there's ligaments in here the entire time. So when we do our epidural injection, we go through the skin, subcutaneous tissue, supraspinous ligament here, interspinous ligament here, and ligamentum flavum. The ligaments are very hard, and you can't really inject fluid into them. The pressure is very high. So when we use a loss of resistance technique, and as we push our plunger in the ligament, the pressure is very high. As we come out of the ligament and enter the epidural space here, this space is full of fat. So the pressure is very low. So as we're pushing our plunger, it's not going, and all of a sudden you feel a decrease in resistance and the fluid goes in quite nicely. And when we do the local anesthetic injection here, you can see we're kind of far from the spinal cord. So I'm not worried about injecting in the spinal cord, and my local anesthetics are going to take a long time to diffuse to spinal cord. But you have all these nerve roots that come out of the spinal cord that traverse the epidural space. So the local anesthetic goes to these nerve roots. So depending on the level that I do the injection, so let's say if I'm doing a T1 injection, and when I do the T1 injection, some of the local anesthetic goes cephalad, some of it goes caudat, depending on the volume that I inject. So if I inject, let's say, 10 cc of 0.5% bupivacaine at T1, about 1/3, I'm guesstimating, about 1/3 is going to go cephalad and 2/3 going to go caudat. So you get some of the lower cervical and all the upper thoracic with that volume. Now, if you inject 40 cc, you're going to get the entire dermatome. So it's going to be a very dangerous kind of a picture. So if I do a epidural injection at my L3, L4, or L4, L5 that we typically do for labor C-section, labor epidurals, some of the injection goes up, so we typically end up getting, based on the normal volumes that we run, we start covering mid-thoracic to lower lumbars. Keep in mind, here we're not going all the way down to sacral and coccyx, unlike the spinal. So with spinal, you cover all the bottom ones, bottom dermatomes, and depending on the volume, the higher you go. With epidural, the volume determines how far up and down you go. And with epidurals, we're not injecting around the spinal cord, so we can do it anywhere in the path. We can do cervical epidural injection. No, that's not a problem. You can do a caudal injection that enters the sacral hiatus. Anywhere in between, you can do your epidural. But with spinal, we're limited by where the spinal cord ends at the conus medullaris. So in adults, it's L1, L2. So anywhere below that, we can do our injection. Hope this helps and clarifies any questions you may have.